Gabs, commence the recording, so whenever you're ready.
Righto. Okay, welcome everybody to tonight's webinar. My name's Gay Dungy and I work in New Zealand at the University of Otago in Wellington. And James, who is going to do our presentation tonight, also works in the same institution and is also our statistician for the JRMS. So I'll just hand over to you, James, and we can get the webinar going.
Thanks, Gay and Peter, for the intro. So kia ora koutou, ko James Stanley tako ingoa. As Gay said, I'm a statistician, so I work at the University of Otago, Wellington, in a number of different fields. And yeah, I've been reviewing papers for JMRS for probably quite a long time now. I can't remember when the first one was done, 5, 6, 7, 8 years ago. And I've been a statistical editor for a while, which basically means I am asked to make a number of decisions on statistical contents of papers from there as well. So in the talk that I'm going to give tonight, I've really the sort of briefing and discussion we had around what to do was to keep things reasonably short. So I've got a few ideas and concepts that are quite common in preparing or reviewing papers to go over, and then we've got quite a bit of time for discussion and questions, which hopefully we'll be able to address on the fly as well.
Can I just interrupt you for a minute there, James?
Yep.
Can I just ask people if they've got any questions, if they can just pop them into the chat as James is doing his presentation? That would be helpful, and then we can see what people want to know post-presentation. Great.
Thanks, Gay. So so the topics I'm going to cover are slightly arbitrary in the sense of that there's not really a theme that kind of runs through this talk other than things that come up with statistics. But hopefully it'll be an opportunity to talk about and think about some of these concepts, and hopefully we'll have some fruitful discussion around some of those concepts as well. Hopefully I'll be relatively onto it. It's not super late here, but I sort of got home, put all the kids to bed, and was just putting the finishing touches on this. So I'm hoping I'll be relatively onto it while presenting. So here we go. Okay, so we often like to do these things in fives, and I started off with 5 points to potentially cover in this first session here, and then I collapsed a couple of them because I thought actually it was really one follow-on point to another. So the sort of theme that I've given here is thinking about, I guess, common things that come up in papers. So in some ways, these are rules of thumb that we often learn when we're starting out with statistics, thinking about how to approach data analysis, how do we make sense of data to draw conclusions. And in some instances, those rules of thumb are useful, and in other instances, those rules of thumb potentially occlude a more complex issue that we should actually be concerned about, or lead us to worry about something that's not actually worth worrying about as well. So I didn't really review the order that these items were in, but I'm going to start off with a general overarching principle, which is that what we kind of do in the design phase of a quantitative study should follow through really to the analysis phase. So I'll talk through some instances of that in a moment with a few examples as well. The second point, so I'm just thinking I should put a watch somewhere where I can see it so I don't go too far over. So just take my watch off. The second point was deciding on the choice between parametric and non-parametric tests. So again, in part, this talk's motivated by common things that I see when reviewing articles for the journal. So we'll talk about some issues there and some decisions and what the pros and cons of those tests are as well. The third one is really a topic for probably at least an hour-long discussion as an introduction. How big a sample size is needed? So I'm really just going to touch on some principles to think about really when thinking about how big a study should be and what the processes should be for determining that. And the last item, I haven't really come back and reviewed this outline title, which I've called "Do results need to be significant to be useful?" The answer to that is a no, but just to unpick a little bit what the statistical terminology around significant and non-significant results means, those of you who've been following the research literature not the research literature, but really the research paradigm more broadly, will know there's been quite a lot of discussion of this in statistical and extra statistical circles of late, in terms of think about, how do we make use of statistical information, and trying to move ahead from what's been a relatively dominant paradigm in a lot of health research in particular. This whole idea of, statistically significant means you can say something about your results, and non-significant means, there's nothing in particular going on. So that's really just a very quick taster of that topic. So the first point I wanted to make was said that design should lead to analysis. So the type of study that we're doing, how it's structured as a study, and the choices that we made going into that all need to flow through to analysis. So at a very broad top level, if you think about randomized trials, when we're thinking about treatment evidence and quantitative studies, randomized trials kind of sit at the top of single study designs for thinking about causality. And that's largely because by randomizing individuals to receive one treatment or another treatment, what we're effectively doing is making those two groups as similar as possible on everything but that one treatment difference. So that's really key. Now, there will still, my second point under here is that there might still be differences in those groups at baseline due to chance. Let's say you get a few more women in one arm of the study than the other, and that might be related to the study outcomes. So you might have a few people who have a higher level of disease severity at baseline in one group rather than the other group. But those processes should be due to chance, provided that your randomization process is fair and people aren't trying to game the system. So the key issue really then with analyzing randomized studies is you should work really hard not to undo that randomization. So we want to avoid bias in post-randomization decisions. And this is really, if you know a little bit about randomized trials, you'll probably have heard about things like intention to treat analysis and per protocol analysis. And per protocol analysis is a good example of undoing some of the steps of randomization. So if you look at the people who actually followed a treatment protocol, so say patients who were able to or willing to complete all of the treatment elements, if you subtract the people who didn't comply, for want of a better word, with those treatment processes from your analysis, you're essentially going to be reintroducing bias into your study, because all of a sudden you've taken out people who you don't really have a good match for in the control group. You can't identify the people in the control group who would have been the people who wouldn't have engaged in your intervention. So that's a key point there. But protocol analyses are quite useful in a lot of instances, but it's they are a little bit troublesome to think about and interpret because of those post-randomization decisions. Thinking more broadly about observational studies in their very general sense, so that is non-randomized trials really, especially when you're comparing two groups, say a particular treatment group with another treatment group, but you've just got data from patients seen over the last 4 years, for instance, then we need to be worried about confounding. So that's really to say that those two treatment groups are going to have particular factors that differ between them. So there are going to be systematic differences as to who received treatment method A and who received treatment method B in those study elements. So in some instances, if you've got a prospective study, you might be able to address that confounding by design. So you might be able to balance the groups by some kind of matching process to say, okay, well, we're going to select equal numbers of males who've received treatment A and equal numbers of males who received treatment B, and that will reduce the imbalances between those two groups. That's not necessarily particularly efficient. More commonly, that is done through analysis, so through regression methods, for instance, where we talk about, for instance, adjusting for differences between groups. These are quite, those are the more basic methods. There are some quite extensive other methods out the other side as well for that. The third point that I wanted to make is that, as well as these very big level picture, big picture issues, we need to think about the data structure as well that we have. So one of the key things I wanted to talk about today was think about independence of the observations we have. So when we have paired data, for instance, if your data are paired, so that is if you've got repeat observations on the same people in most instances. If you've got repeating observations on the same people, then you need to account for that in your analysis phase as well. So unless I've stated otherwise in here, all of the examples are from JMRS. And so I've just given the DOI up here if you would like to follow these later. So this is from Yan et al., a study looking at head and neck cancer patients receiving radiation therapy and getting prophylactic treatment with either Mepitel film or biofilm cream to reduce skin reactions, in short. So in this particular case, the side of the neck which received which of these two treatments was randomized. So what that effectively means is that each patient is acting as their own control. So half of the potentially affected area is getting one treatment and the other half is getting the other treatment. And what that means is that actually when we're interested in comparing the outcomes for the two groups here, this is on the RISRAS scale. So this is basically self-rated over here and self-rated being the patients and researcher rated skin reactivity, and the combined score is on the left here. We have measurements from the same person under the two conditions. In this particular case, the paired test was used, which is appropriate. In this case, it was a Wilcoxon signed ranks test, which is, you'll see lots of different people's names attached to different statistical tests, of course. And in this case, this is essentially the equivalent, the non-parametric equivalent of a paired t-test, if you're familiar with that methodology. So in this case here, this returned a p-value less than 0.001. That is, if there's really no difference in the sort of distribution, so to speak, of RISRAS scores between being treated with the film or being treated with the cream, then you wouldn't expect to see this bigger difference between the two groups. So the key advantage of using a paired test here is that we're essentially subtracting out, by having each patient X their own control, we're subtracting out some of that inter-individual variation from the results that we have. So some people might have particularly skin that's prone to reactions, or the treatment might mean that they're at higher risk of actually getting a reaction from the exact placement of where the RT is being focused. So if we had used just say a standard unpaired test in this case here, we would have ended up with a higher p-value for it, because we haven't been able to subtract out that intra-individual variation. So we have introduced a couple of extra concepts in here, which I'm going to unpick in a second. One is when you might choose, as here, to use a non-parametric test. We'll come back and talk about p-values a little bit later on as well. So I'm going to talk a little bit now about non-parametric tests. So these are technical terms. I don't think I've given a good example in the coming up slides as to what a parametric test might look like, but parametric tests are generally where we're estimating parameters and we're reporting those with precision. So if we could have used a parametric test here, what we would have been doing is estimating the difference between the black bar and the gray bar here to say that the film leads to RISRAS scores that are lower by about 1.2 units. So that's an example of a parameter that we might be estimating, the mean difference between those two treatment conditions there. Non-parametric tests, on the other hand, are generally rank-based methods. That is, in here, when we're comparing scores, it doesn't matter so much whether the absolute score for a particular patient is 4 or 3 or 2.7. It matters if it's the highest score or the third highest score, and so on and so forth, or the lowest score in the sample. So we're effectively comparing those ranks. So those lead on to the strengths and weaknesses of these two different methods. So parametric tests make more assumptions about the underlying population data. So there are more requirements that need to be met for those tests to be sensible. We'll talk a little bit about normality assumptions in a second. Non-parametric tests make fewer assumptions. So in that way, they're quite nice, that there's no particular requirement for data to be, say, normally distributed to apply them in particular cases. However, they tend to give vaguer answers. So we'll talk through the example that we were just looking at in a second to think about what that means. What it means is that we can't report effect sizes or confidence intervals from these tests. So that is a little bit of a problem if you think about, say, meta-analysis as being one end goal of this kind of research process, that we want to have results that can be combined across multiple studies, because for meta-analysis to work, you do have to be in this kind of parametric setting here where you're estimating, for argument's sake, let's say you're estimating a difference between two treatments. You need to have an estimate of how big that difference is and how precisely we know that difference from a statistical point of view, whereas a non-parametric test will just tell you people tend to score more highly you know, on this skin reactivity test if they were given treatment B than if they were given treatment A. So it does make it harder to combine results across multiple studies. A slightly unrelated issue is that if your data meets the assumptions for parametric tests, the non-parametric tests tend to be less efficient, which in a statistical sense means you get less power or less precision for the same sample size. So if you're in a hypothesis testing framework, a non-parametric test in a situation where a parametric test would have been reasonable is less likely to return a significant test result. So that's so we don't want to be overly conservative in terms of choosing the type of test here. So I'm just going to come back. This was just because I had this particular paper and I thought it illustrated this next point as well. In terms of deciding on when a particular type of test is sensible or not. In this particular case, the test type was pre-planned in the paper. So we already kind of know in advance of this that actually these scores tend not to be normally distributed. So they have a particular pattern that makes them not particularly germane to using things like t-tests or related methods for them. And so that means going into this this particular piece of research, there's already a plan in place to say, look, we're going to have to use a non-parametric test later on. So that has the advantage that it's not a data-driven decision. So that's a pro in this particular context here. On the negative side of this, though, as we said, this only gives us a relatively vague answer. So this particular graph here does show you what you might conceptualize to be a parametric difference, even though the test that's behind it is just asking whether scores tend to be higher with cream than with film on average. But we get an answer to that global kind of question. So yes, on average, scores tend to be higher for the cream than with the film, but we're not formally testing how big that kind of treatment effect is, so to speak, or how precisely we know it. And again, that's problematic, especially if you had, say, a series of studies and you wanted to compare or think about which treatment might be best. The non-parametric tests are really giving you statements about whether you should believe the data are consistent with the difference, but they're not telling you how big the difference is or how important it is. Now, so I will say for many of the other citations I'm giving here, I haven't read these papers in full, and actually for this particular one, I've just picked it out because it had a nice quote of something that I quite often come about, rather than that this was an inappropriate thing to do. So I just wanted to say that in advance, particularly because there may be people here as well who've been co-authors on some of these papers or have been involved in this work. So in this particular test, which I've already forgotten what this study was about actually, but they say that while they used a particular test, this Kolmogorov-Smirnov test, to decide whether the data were approximately normal or not. And then because they were not normal, they've used this Mann-Whitney U test, which is a non-parametric test. So this is quite common as a statement to see in papers. Basically, we looked at the data we had to make a decision about whether a parametric or a non-parametric test would be sensible. So there are a few issues with this. One is that the technical assumption is not whether this particular sample, so this particular data that you have in front of you from your, say, 80 patients in your study, show patterns that are consistent or inconsistent with a normal distribution, but rather whether in the population you're drawing from, whether those values are going to be approximately normally distributed. So I think in a lot of cases, we already know in advance which variables are going to be problematic from a parametric test point of view. So of relevance to imaging work and to some treatment work as well, volumetric quantities. So if you're looking at the size of a tumor or if you're looking at the shrinkage of a tumor, those don't tend to scale in a linear fashion. So as you get a bigger and bigger quantity, you have these properties of what the numbers look like, I guess, that don't follow a normal distribution. And so we tend to prefer either non-parametric tests for those or some kind of transformation of them to analyze them. And the same is true for some assay type results as well. So for instance, looking at something like prostate specific antigen levels, where again, most people have low to relatively low scores, but some people will have very high scores on that. So that's the ideal situation you want to be in, is where you know from past work what is a sensible analytical approach to the Sorry, my microphone just turned off for a second and it's probably just deciding what it's doing now.
We can hear okay.
We can still hear you.
Yep, I think the microphone will probably still stay on the webcam now, but so if my thing turns off again, I'll just keep an eye out for thumbs up on that as well. So yeah, so if we're looking at our studies data that we have in front of us, it won't necessarily choose the optimal test for a given scenario. So if we're constantly making that decision based on the data that are in front of us, that's not necessarily going to give us the best choice that we want. So a follow-on consideration from that is thinking about when we say that data need to be normally distributed to analyze a test. That's another thing that we might quite often hear, and it is a relatively gross simplification about what is going on. So different tests, different parametric tests, have different assumptions about what the population distribution needs to look like in order to return reasonable and interpretable results, really. So in the case of a t-test, for instance, where you're comparing means between two groups, by and large, that is driven by whether the scores in our two groups are approximately normally distributed. For linear regression, on the other hand, so here we have an example from a paper here that's showing change in PTV volume on the x-axis and change in mean heart dose and grays on the y-axis here. We can look at this data, so I can eyeball this data, and you might not be able to see this so well, to see that actually when you look at the y-axis values, so the change in heart dose, most of the data is sitting pretty close to zero. So you can see it kind of in this sort of bottom part of the graph here, but then there are quite a few values that are actually quite high in there. So that's going to be not normally distributed. That's clear, and I think if we chose some other method to plot that, we'd see that as well. However, for linear regression, the actual assumption is that the residuals from this line of best fit that we have from here, which is our sort of correlation linear regression sort of summary line of best fit through the data, that is the residuals. That's basically what's the difference between the observed value and the predicted value. So the spaces between each dot and the line should be approximately normally distributed. In this case, the data is not too bad in that respect. If you could imagine kind of rotating this figure so that that dotted line is completely flat horizontally, then what we're asking are, are the points sort of approximately normally distributed around that line? And in this case, that's going to be reasonable. So again, more complex analyses have more complex requirements, and quite often we can't tell from a simple summary what's going on. So here again, this is a quite reasonable use of this particular method. In this case here, this is not a situation that's particularly worrying, and this is one of those instances actually where people might make a more conservative decision to say, well, actually your outcome has to be normally distributed for there to be reasonable results, and it's more conservative than is needed. So this is really just my one slide on how big a sample size is needed. So sample size considerations are most useful when you're planning a study. So working out how big does the study need to be in order to return useful results, and there are a number of different ways you can do that. From a writing and reading a paper, having justification for the sample size is important, because you want to know actually that the study was capable of returning a reasonable result heading into it. There's some quite complex reasoning out the other side of that, but just more generally as a reporting principle to say, look, there was a plan to get some data and we achieved that, or we didn't achieve that, and hence that's going to have critical appraisal quantities associated with it. So in order to be able to do that, we need to think about, how big a difference is it important to detect between groups and a randomized trial situation, or how precisely do we want to estimate an association for a different type of study. So that's going to be really dependent on the question in hand. And one, this is where rules of thumb are particularly problematic, because there really isn't a rule of thumb for sample size as to how big a sample size is useful. And sometimes you do see people say, well, actually, for parametric tests, you need a sample size of about 30. And that's to do with this thing called the central limit theorem in statistics, which is basically about, if you're using parametric tests, how big a sample size do you need for the test? I guess I sometimes describe it as being mechanically workable. In other words, can you use this test to return a valid statistical result? But sometimes this gets interpreted, if you've got a sample size of about 30, that will allow you to get useful answers from your questions. And those are quite different issues. And a sample size of about 30 is in many instances, going to be too small to address real questions. But again, that's really dependent on what you're looking at. For some outcomes, that might be about right. And for other outcomes, you might need a sample size 5 times or 10 times as large. So that leads on to the last sort of topic that I want to talk about, which really is about this whole issue of p-values being less than 0.05 or greater than 0.05. And so this is going to be a real quick over the top kind of overview on this. So when we have non-significant results, one of the big problems with interpreting them is that these are quite often interpreted as saying there was no difference between groups, and that's a real critical issue for interpreting non-significant test results if you're just working off the p-values. So ideally, you need to interpret these kind of results with caution. I've got some examples in a second of this as well. And one thing to think about is when we're looking at p-values is that a p-value is really a statement about how well your data fit with a particular model. And that particular model is often that there's no difference between groups, so there's no association between two particular variables. So when we're thinking about study results and we're using all the information we have from a statistical point of view, so p-values and confidence intervals, what we're really asking is what's going on in the population. So what kinds of real phenomena are the data we have in front of us consistent with? And p-values are quite a reductive statement on that. We're basically saying, well, you'd be likely or unlikely to see these particular study results we have in front of us if there's really no difference in the treatment effect between these two treatments. Whereas actually what we want to say is that actually these results are consistent with something ranging from a moderate but still important difference at one end up to a very important difference at the other end. All these results are consistent with either a negative effect in one direction or a positive effect in the other direction, but neither of those results is necessarily that important. So from a publication point of view, ideally we'd like to publish well-conducted studies regardless of statistical significance. So I've said when I talk about well-conducted here, that does mean adequately sized in that respects. But if you had an RCT with similar effects in the intervention and control arms, that's still important to publish regardless of statistical significance at that point. And I think one of the key messages that we'll see in a second is that sometimes the key results there might be indeterminate. And there is in the world of RCTs, which I don't do a lot of work in, there is this kind of persistent terminology about calling things negative trials. So in other words, a study which returned a non-significant result, and in some ways they're kind of treated like second-class study citizens in a sense, whereas actually in most instances that's a highly valid finding and a really important result to have. So being able to say, look, we've tested these two treatments head-to-head, and it doesn't look like this new treatment's any better than the existing treatment. That's a really important finding. So you might contrast that with my made-up terminology here, a failed study. In other words, a study which wasn't able to produce evidence that could be used to answer its aims and research questions. So the studies from this figure is from an editorial that was in Nature a couple of years back now, from an article called Retire Statistical Significance, and this is intended to be like a mock forest plot here, where this vertical bar is indicating, say, that a particular treatment has no effect, and And what you're seeing here is two different studies where the observed result, that's the dot in the middle there, is the same in the two groups. So it might be, say, a reduction in, or let's say it's a increase in, I'm just going to make up a study presentation here. It might be an increase in survival of 20% with a particular treatment compared to existing treatment. So at the top here, we might have, say, a confidence interval on here that ranges from a 10% increase in survival to a 30% increase in survival. And this particular example here would be a significant study, so a study that has a p-value less than 0.05. So here you'd be quite comfortable saying, well, actually, there's there's pretty strong evidence from the study that this new treatment increases survival. Here we have an example of what we might label a non-significant study where there's an increase, similarly observed increase in the sample of, say, a 20% increase in survival, but actually probably usually due to sample size, the confidence interval might be as low as, let's say, 0.95. So in other words, a 5% reduction in mortality. Sorry, a 5% reduction in survival with the new treatment compared to existing treatment, or as high as a sort of 2.2-fold increase in survival. So from that perspective, if you're reliant on sorry, I think there's no audio on my speakers, on my headphones coming through. It just decides to turn off when there's been a few minutes without anything on it. Hopefully they'll be back online till the end. And so, sorry, just remember where I was. So if we're reliant on deciding whether results are statistically significant or not, we'd interpret these two results differently in this particular case here. But when we're looking at the results, you can kind of see that actually they're broadly consistent with one another. So this example, second study here, the red line is what you might consider or think about as being a sort of an indeterminate result. That is, we can't really quite tell what's going on, but the data we have from our study are consistent with potentially quite a big difference in improvement in survival at this end, or a small difference against the current treatment at the other end. So that level of interpretation is quite important. So this is my last slide before getting on to a bit of proper discussion time. This is just to show, and again, this is from another paper from JMRS, and I just want to point out that the authors didn't actually make the flawed distinction I'm about to make in this particular instance. It was just a neat example of where this thinking can lead you. So this is looking at research interests of people working in medical imaging versus allied health professions. And so there's a comparison being made, as to whether those two groups are different in terms of, in this case, I've just pulled out because they were nice and neat to contrast whether they were interested in using quantitative methods or interested in using qualitative methods. These are independent questions, so it's not a choose one or the other. It's how interested are you in using quantitative methods and how interested are you in using qualitative methods. It's a little bit hard to read here, but you can see that, for instance, of the people who said they had no interest in quantitative methods, that was 25% of the medical imaging group and 10% of the allied health treatment group. Whereas for qualitative methods, it was 22% and 10% there. And you can see the results going through. It's not the most straightforward presentation to read in a hurry. But what we see on the right-hand side here is that this top line's been flagged as being significantly different. That is, it looks like there's a difference as to whether medical imaging and allied health professionals are interested in treatment, in quantitative methods. But if you take a strict interpretation of p-values down here, we don't quite have enough evidence here to say that actually whether there's a difference between the medical imaging and the allied health therapy professions down here. But if you look at the numbers in brackets here, you see actually there's not a lot of, if now I'm comparing what results we got up here and what results we got down here, actually those two sets of results look pretty similar to me. There are a few differences here that might indicate some different patterning between the two. Excuse me. There are a few differences that might indicate some patterning between two, but broadly these two sets of results are consistent. So we end up in this slightly weird position where you might say actually there are differences, and and allied health professionals in this case, I'm presuming the argument is might be more or might be less I think if you look down here, there's more interest in using quantitative methods in the allied health professionals if you start from the bottom and look up than there is for the medical imaging profession, where your interpretation down here might be that there's no difference between groups, but actually these two sets of results are broadly consistent with one another. So so that's really just to illustrate the pitfalls of relying on p-values at that point there. I'm going to stop sharing slides there. As you can see, I've completely failed to keep that to anywhere near within 15 minutes or so, which is one of my key problems with giving a talk for the first time. So I think now if people would like to ask any questions on these topics or anything else, I'm very, very happy to address those as best I can from here.
Just while we're waiting for questions, James, can I ask you how you got interested in studying statistics or teaching statistics? What was your passion that drove you into this line of research?
Yes, it's a good question. I think so. My background before I moved into statistics was in psychology. So I did a PhD, quantitatively focused PhD in psychology, and then a sort of postdoctoral position in cognitive neuroscience. So to some extent, at the end of that process, I was not quite disillusioned with experimental psychology. I was interested in doing something with a bit more in terms of a bit more scope in terms of real world implications. So I essentially was quite keen to move into health research, and so did have a reasonably strong background in statistics at that point, although effectively my first job as a statistician was in many ways an apprenticeship in working in statistics and health research. I think so. To tweak that question slightly, what's kind of kept me in statistics in health research is you get to see a lot of different studies and a lot of different research questions. So it's quite nice from that perspective to be able to participate in and contribute to lots of different bits of research. Yeah, and so I don't know. I mean, at one level, I find some of the day-to-day work reasonably satisfying, but yes, the bigger motivations are more around sort of research topic questions and what sort of outcomes we can hopefully achieve in that applied setting. Yeah. It is, and this may be a little bit counterintuitive when we think about stereotypes of statisticians, is that it's also a good way to get to talk to lots of people about lots of different things as well. So you know, on a good day, it can be quite social, albeit that you're often talking about relatively nerdy things around.
Yeah, I think that's one of the exciting things is those conversations, but also learning about other people's research. And I guess you'd also have to be a bit of a problem solver too. So you've got an understanding of the field, and you know what sort of tests might apply best in certain situations. So you're trying to find a solution to a puzzle, I guess, in some ways.
Yeah, it is interesting. I think, and I sometimes describe myself in this way that I have like maybe one or two good independent research ideas a year, which is enough to keep me busy around all the other work that I'm doing. But yes, it is quite nice. It is kind of a constrained. Someone has a constrained research question they want to address or that they've started addressing, and so you know I've already got some kind of limitations on what you might or might not be able to do. So there's not, you know, we often can't find an answer to those questions. But yes, no, it is nice from that perspective. Yeah.
Now it looks like we've got a question that's come through. This is exciting. The first question. So this question is just asking, James, what software for statistical analysis would you recommend for novice researchers, please?
Yeah, that's a good question. And I have so to think more broadly about statistical software, it kind of ranges between what is sometimes pejoratively called point and click software. So for those of you who've used something like SPSS before, that's where essentially you're clicking on menus to select which variable you want to analyze and so on, and you're clicking on to choose particular tests and so on. And I think for most people who are starting out in research and statistics, those are quite good choices. One, because you often know how to use those particular types of tools already. They look somewhat familiar. So in SPSS, you've got something that looks a bit like an Excel sheet that has your data sitting there. and and then you can choose the types of tests you want to do and the graphs you want to draw and so on and so forth. And so what that means is that you can concentrate on the bits that you want to concentrate on. So understanding what data is going into your analysis, understanding what types of results you're getting from that analysis, which are the key bits you want to consider. The more complex statistical software tends to move towards more programming-based software. So the software that I use, which is R, is in the letter R, which is freeware software, but is quite widely used internationally, is very flexible and very, I guess, powerful in the sense that you can do lots of quite advanced things, and there are lots of people working on extensions for it. But the big trade-off for that is that actually you do have to learn to be, at one level, a computer programmer, which is you don't actually need to be a computer programmer to do it, but you have to be comfortable running commands in a program, and to get the best use out of it, you have to know, how do you go about actually keeping records of the code you're running? So what we might call writing a script or a program, really, so that you can make your research repeatable. So there are trade-offs, and so I think my extended answer to that question, I won't give the extended answer, but the flavor of my extended answer to that question is think about, well, where do you see yourself going longer term? So for people who are starting off, say, on a master's, PhD type journey, where they're thinking, well, I'm doing some stuff now and I'd like to keep doing research throughout my professional career, both as a researcher / clinician or just as a researcher, then it might be worthwhile learning those tools and picking them up and working with them later on. But if you are the kind of person who might do 1 or 2 things a year, for all of us, it's kind of like, remembering how you do stuff in different software is tough enough, let alone when you're only doing it a few times a year. So SPSS, it's limited in some respects, but it does do most of the statistics that we might commonly need to do quite well. Then there are some, if it is commercial software, there are some sort of freeware equivalents that are available. We used to use a package called EpiInfo, which is still around. It was developed by the Centers for Disease Control in the US, and that does a lot of very similar stuff to SPSS, but it's more freely accessible.
Do you have a thought on people using Excel to do statistics?
Thanks, Peter, because I was just trying to remember what my other point I was going to make, which is, so that would be the temptation, I think, for a lot of people starting out, is to use Excel, because it does include some statistical functionality. So you can obviously calculate averages and things like that in there, and you can do slightly more complex analysis, like well, t-tests are not overly complex, but you could do a t-test in there. You can do some regression methods in there. I would generally recommend not using Excel for a couple of reasons. Some of them are that it's just more open to user error. So you could quite easily try to compare 2 groups and accidentally leave 5 people from one group off by just not selecting enough cells on the left-hand side, and you would never necessarily notice that. So that kind of thing can happen very easily by accident in Excel, or you might select completely the wrong column. I suppose that can happen elsewhere as well. Whereas in a more formal stats package, you have to work quite hard to accidentally exclude people from that. I think the other reason to try and avoid Excel, I still use Excel for a lot of things. So I think it's, if you're calculating descriptive statistics like means and standard deviations and so on, it's quite handy, and you can see the results right in front of you. You can see the analysis kind of right in front of you, and you can see how it comes out. So it is quite nice in that respect. So I sometimes use it for what I might call like prototyping an analysis. So having a look and an explore, because it's quite accessible. But otherwise you will run into issues. The other issue that you might run into is that you might find it quite hard to keep track of your results as you go. It's still a little bit hard with SPSS, but you can kind of save your result outputs more easily, I think, in SPSS as you run through.
Okay, we'll just whiz on to the next question now. So the next question, this is a good one actually. When do you think it's necessary to consult a statistician as opposed to kind of soldiering on and completing the tasks yourselves? At what point should somebody consult a statistician?
Yeah, that's another really good question. And again, I have slightly conflicting answers because as a somewhat busy person, I always like to say to people that my door's always open for advice, but sometimes it's not open for a few days down the track. And when we're all working on our own projects, we like to keep the momentum going. So I think it is tricky to answer. I guess at one level, if you're familiar with what a statistical test does and you're happy that you can interpret the results from them, then I think sensible to proceed in that respect. But if you're unclear as to what a test might do, or if you haven't really worked in a particular paradigm before, I think it is useful to talk to someone, not necessarily a statistician, but maybe just someone who is reasonably experienced in statistical methods. That can be helpful to think about what some of the pitfalls are, because there are a lot of things where it might be, well, okay, that's on the face of it, that sounds like a good idea, but there might be A, B, or C, or you can get a much quicker way of doing it using this this other method here as well. So I think there are some more complex methods. I think particularly when you get to observational studies where you're interested in comparing two or more groups and you're worried about the potential for confounding, that becomes reasonably complex to do. So I think it is good to get input on those where possible. But I appreciate we're in somewhat short supply and reasonably high demand, so it can be hard to get timely advice, unfortunately. And the flip side of that is, of course, the internet, as with everything else on the internet, is full of people who would like to be helpful or think that they can be helpful from a particular presentation, but may or may not actually be able to give you good advice on things as well. And it is a little bit tricky because unless you're sort of versed in these things, it can be hard to tell what is sensible advice versus what is less reasonable advice. Yeah.
And would you say, if you are going to consult a statistician, perhaps do it before you collect the data so that you know that what you're going to collect is appropriate?
Yes, I think I would agree with that. It can sometimes be hard. This comes back to Peter's point. I think it can sometimes be hard for statisticians. I sometimes find it hard to provide advice in the abstract about a particular project, and sometimes it is easier to conceptualize what the statistical approaches might be when you've got either a little bit of data or you've got a slightly more concrete plan in front of you. But more generally, I think, yes, it is good to talk early, talk often was a topic that I gave to PhD students. So get in relatively early in the piece to try and gather the information you might need about what approaches might be sensible. Then you can sort of digest that. And yes, if you're doing that before you're selecting the test and choosing what to do, that's really useful and really important. And in my experience, it's often about as much work to have, say, 3 conversations with someone about what they might do design-wise and going in, as it is to try and solve the same scenario for someone who maybe didn't have those conversations at the start and came in near the end with something that where you didn't have that sort of catch on those earlier steps. So it is definitely useful to talk to someone earlier, and mainly that's around, as you say, Caroline, it's mainly around what data are you collecting, because that's the bit that's kind of, and who are you collecting it from, because those bits are unredoable without starting a study again from scratch, whereas analytical choices, quite often you can refine those as you go. So if you talk to a statistician, they say actually it would be more sensible to approach the analysis this way than that way. You might well have all the data you need to do that, and you can redo that, but it's those bits that you can't redo that are tricky. Yeah.
Sounds
And
like
as opposed to, sorry, Peter.
I was just going to say, it sounds like for a big project, it might be worthwhile trying to pilot a small data set and try and build that into your design, and just sort of pause and analyze and reflect before you go on to the final data collection. Yeah,
I think quite often for RCTs, I guess it's quite common to do sort of feasibility studies, which are more about how can you collect the data and what might the pitfalls be. It can be trickier to do a pilot in the sense of get a little bit of data and make decisions about what to do from there. But sometimes we might have discussions with people where they've already got some of their data and they're getting more in, and they know that's what it's going to be, but they might bring along the data that they have so far to have a discussion at that stage. I have to say sometimes, yes, I'm not very good at giving I tell people, please, it's good to come and talk earlier, but there are lots of times where people have talked to me earlier and I still haven't found the bit that I could have successfully advised on until after everything is collected and you're working through it, which is frustrating for everyone, and it does, we do have those issues as well. Yep, at our end of not thinking about what the really key thing is.
I was also just going to say, I know I'm not particularly statistically minded, but when I was doing my PhD, I did some stats, and I'm just looking at the literature, sourcing papers that had done similar things, a good start as well, before I then kind of went to my statistician friends to, so reading a bit more widely in terms of the literature, to give you an idea of what's been done, peer reviewed, hopefully peer reviewed to a high standard, that you can potentially get some ideas from as well.
I think that is really useful, and I think again it's kind of because obviously there is stuff that gets peer reviewed and published that perhaps isn't the best approach to a particular source of data, but actually that's where you've got a concrete example to say, look, this is the kind of thing we're thinking about doing, and this is the approach that other people have been using. Again, it gives us sort of a concrete plan to sort of think about, and then think about what the sort of counter proposals are as well in that respect. Yeah.
Okay, we'll whiz on to the next question. So, can I please ask for your thoughts on making a heat map for data analysis to show the correlation between data? Heat maps and correlation.
Yes, so I have to say I haven't really
context is, but
yes, I haven't really used heat maps in particular. So is this in the context of is this more in the context of imaging, or so this, I guess, is a question for Zara. Is this more in the context of an imaging type study, or is this more in the context of a more general sort of analysis type study? Feel free to jump on the microphone, I guess, if that's easier than typing out. Yeah. So for those of you who aren't looking at the chat, that's in the context of imaging. I mean, once upon a time, I did work a little bit with heat maps. That was when I was doing cognitive neuroscience stuff with functional MRI things. But actually, in that case, the software was like a dedicated, essentially black box for doing this kind of analysis. So I never had to give it much particular thought. So I don't think I'll actually have a very good. I won't pretend that I could come up with a reasonable answer to that question. I'm sorry, Zara. In that respect, there are some good tools for making them. So I guess again, in software like R, you can quite often draw heat maps. But I suppose if you have some actual imaging data and you want to overlay heat maps on those, that can be more complex to do.
And in the absence of any other questions, can I just perhaps ask, this is a bit of an open question, what are the things that people will, what are your top 5 things that people come and ask you?
Good question. This is one of those things where I quite often say where I got a few different roles. One of them is kind of like which I don't spend as much time as I used to, but kind of like being a GP of the statistical world. And I got GP colleagues who say everything is common in general practice, but it's all rare. So like back pain, they'll say, oh yeah, we see so many people with back pain in primary care. And then when they actually review their records, it's like, well, they saw 3 people last year kind of thing, or 5 people, or anyway, a smaller number than what you might expect. So I think partly to do with who I'm working with, quite a lot of the stuff is thinking about sample size and planning for studies, which is partly because the calculations aren't super complex, but it's one of those cases really where the decisions you make going in are the major driver of how good an answer you get out. So I do spend quite a bit of time on that. Otherwise, I'm trying to think what might be relevant for this group. The common things that we often talk about or ask about, I guess, in these settings is thinking about what kind of information can someone draw from a study. So it's not uncommon to have someone say, look, I've got this data set I've been collecting for this study. Here's what I was thinking to do. What sort of stuff can I do with it statistically? So we do spend quite a lot of time talking about, I guess, the difference between hypothesis testing. So that's what quite a lot of people have learned in statistics. How do you compare groups A and B and decide whether they're different? And trying to reframe that more into a sort of an estimation type frame to think about, look, we want to get an idea about how big this phenomenon is in this group. So like the prevalence of a particular health condition, that's often not a hypothesis testing situation. It's just putting a number on it, say 40% of patients have, access to care issues, and saying, well, given our sample size and so on, we don't know that number perfectly. So maybe it's as high as 30%, sorry, as low as 30% or as high as 50%. So sort of reframing those as confidence interval type questions. I do get, and I'd like to get fewer of them just because I can't answer them particularly efficiently. A lot of questions about how to do particular kind of semi-complex analyses using statistical software, but those are all quite distinct and different as to what they do, I guess. So I think sample size things, thinking about how to extract knowledge from data, but that's a very vague way of saying what statistics might be useful in this situation. So in some ways, even though again it's quite rare and it tends to be, I'm possibly just saying it now because we're coming up to sort of grants season in New Zealand, and so everyone's sort of thinking about planning their study designs in that respect. Yeah.
Can I ask a question, James? What's your go-to textbook? What do you refer people who are working in medical radiation sciences to go and have a look at if they're thinking about designing a study and choosing different statistical tests, or they're in the middle of trying to analyze a data set? Is there something that you think is quite appropriate for this cohort for us?
Yep, and I can. What I'll do after this meeting is I can send through a couple of links or suggestions that might come out. I've got a couple of textbooks which I think about 3 that I recommend. One, my top one is called Essential Medical Statistics by Kirkwood and Stern. One, because it's explained in relatively non-technical language, which is good. So it's quite approachable for, like, my background isn't mathematics, so that's good for me. It tends to concentrate on the conceptual side of things, but it does have a little bit of extension of things to go into a little bit more detail on the technical side of things as well. However, that's framed from a more sort of public health epidemiological point of view, so it tends to be a bit more focused on categorical outcomes, but many of which are, still relevant in a sort of medical radiation setting, so survival analysis type methods and so on. The other 2 textbooks that I have used are Martin Bland's, I think, An Introduction to Medical Statistics, which is a bit more focused on continuous type outcomes. So if you've got like biochemical or some levels of something in the bloodstream and so on, that's perhaps a bit more suitable for that. And then the third one is called Intuitive Biostatistics, which is a very appealing name for people who don't think they are going to be keen on learning about statistics. And it's a quite good textbook. It does try to address things mostly from a conceptual point of view, and that works well for some bits and not so well for others. So those are my sort of 3 go-to textbooks. And I think just think about the types of papers and things that I review for JMRS. Those textbooks will probably cover about sort of half of the concepts and the issues that are covered. And the bits that really don't get covered are, and I think because they're quite specialized, are these things to do with trying to assess agreement between observers, not so much at a simple level of do you classify a person as being patient type A, B, or C, but where you're looking at, say, overlap in in areas covered by a planning image, for instance, or estimating like the volume of a particular object that you're trying to target volume, for instance. And so there's probably there probably isn't a good textbook that would cover those. Not that I know of. There may well be one out there that does a good job on that.
Thanks, James. Have you ever heard of a book called Statistics Without Tears?
Do you know what? I might have a copy of it somewhere in this very room. I do
recall reading it many years ago, and I don't think it had any formulas in it, but it was pretty good at just explaining some of the basic concepts.
There you go. I do have a copy here. You can see how far the bookmark is. That's just where the bookmark was stuck, rather than I've read that far. So I did pick this one up, and I think probably conceptually, I think often these I mean, it's kind of like that's a penguin, so it's kind of like a popular press type introduction to statistics, but it does go into some of the mathematics side of things. So I should probably actually get through reading it to see whether it's useful to recommend or not. But that's a relatively recently revised one. Yeah. Thanks, Peter.
Well, I guess that's pretty much brought us up to time, I think. There's not one more pending question coming through. Oh, well, thank you, James, very much for your time. It's really appreciated. And
That's all right.
yeah, and I'm sure we'll get fed a few more questions perhaps over the next few days. But yeah, thank you.
That'd be great. No, thank you. Thank you, everyone, for your questions and for coming along.
Yeah.
Yeah, thanks a lot, James. I really enjoyed that presentation. What we'll do is when you send through that information, we'll send it out to our people who registered through email, but we'll probably add it to the text section of the Zoom, not the Zoom, sorry, I should say the YouTube video, so we can provide that information as well. Wonderful session. Thanks, James.
Yeah, thank you.
Thank you.
All right. Thanks, everyone. See you later.
Lots
Have
of
a good
thanks
night.
on the chat.
Yep. Thanks. Yes, it's good. Do you hang? I suppose I'll hang around for a few more seconds to bask in the thanks, and then I'll so in case anyone's feeling left out, if they type a thank you and don't hang around for that last bit. Yeah. All right, cool. Well, I'll send through those notes in the next day or two. I presume you've got to process just for getting things up on YouTube and so on. But
yeah, that's true.
I'll sooner I can get those in the better. I probably have them written down somewhere or other already on a website or something. So I'll see if I can find it easily to flick on. Yeah.
Wonderful. Thank you.
Okay. All right. And Gabe, my apologies for not getting anywhere near